name's John, and today I'm doing my presentation on Mycobacterium tuberculosis. So before I start into the actual case study, I want to talk a little bit about the local history of tuberculosis in Kentucky. Being a student at the University of Kentucky and being also a resident in Louisville, Kentucky, I think it's some important history that we go over. In the early 1900s, there was a tuberculosis outbreak in Jefferson County or along the Ohio River, which, as you know, this bacterium flourishes around. And in response, they did open Waverly Sanatorium, which was kind of like a hospital for these people. And it was considered to be one of the most advanced places in the world for treatment for tuberculosis. But sadly, even with these innovations, 6,000 people succumbed to the disease over the lifespan of this now abandoned sanatorium. You can still visit it. They do tours that are historical tours, so if you want to learn about it, or, if you're into it, they can also do ghost tours. So just a little bit of fun information about this, just so you do know that it does exist. So to start off this case study, I do want to go over some of the patient information, what we already know about the patient. It's a 55-year-old male. He had foreign travel. This is a French soldier that was stationed in Djibouti. The abnormal x-rays were present. There was a parenchymal consolidation of the right upper lobe with small cavities. But other than that, he had a really good medical history. There was nothing else wrong. It was pretty prestige. His symptoms: asthenia, anorexia, and weight loss. He lost 3 kilos in a very short amount of time, which is a lot. There's no other symptoms. There was no cough, no sputum, pneumocystis, dyspnea, fever, night sweats. None of that was present. So these things that you traditionally associate with tuberculosis, it wasn't there. First thing I want to go over are the core lab results. So these are things outside of microbiology that they had checked just to see how they were doing. Everything's pretty normal. We are looking at patient 2 on the chart on the left-hand side. The SED rate is normal. CRP, pretty normal. Fibrinogen, slightly elevated. The CBC is normal. There is a slight eosinophilia, but other than that, I don't see anything out of normal. Liver enzymes are normal, and the chemistries, the creatinine and the glucose, those are normal too. So there's not much going on there. They did run some serological tests. They all came up negative. So toxocariasis, trichinosis, amoebiasis, all of those are negative. And they did do a parasitic stool infection, which also negative. But then we get to the bacteriology results. What happened in micro, what grew out, what they seen on the smear. The gastric aspirate smear, negative for AFB, and they held it for 14 days and it was still negative. As for the bronchial aspiration smear, it was positive for AFB. And of course, there are the steps that they use, the N-acetyl L-cysteine and sodium hydroxide for the decontamination and such. They used an aramine staining, and on that positive smear, they did use a Ziehl-Neelsen stain. For our cultures, the bronchial aspirate culture that was positive for our acid-fast bacilli were also positive within 14 days on the culture aspect. But then that gastric aspirate, it later also came up positive. Both of them, actually. As for the media that they used, they did use a Lowenstein-Jensen media, a Colistose slants, and your liquid system, so your BBL mycobacterial growth indicator. And the colonies that grew out were white, smooth, glossy colonies, so these things that we do traditionally associate with tuberculosis. As for the culture isolate, after it was identified with a DNA-specific probe, it was identified to be Mycobacterium tuberculosis kinnetii. Complex form of our tuberculosis. And they also did do our biochemicals. So you have the nitrate reduction, which was positive, the degrees Celsius catalase resistance negative, and your niacin production, which was also negative. So now we do have a lab result. This is indeed Mycotuberculosis kinnetii. After we know what it is, we need to figure out how we need to treat this patient. So originally they placed them on rifamycin, isoniazid, ethambutol, and pyrazinamide for 2 months. But after we got susceptibilities back, it was shown to be susceptible to all primary antituberculous drugs. So after these sensitivities came back, treatment was extended for 4 months using rifamycin and isoniazid. And we had a good outcome. He did survive this, and he did well with this treatment. So I think there are some important points that we need to take from this case. First of all, he was immunocompetent. We don't have an immunocompromised immune system. We don't have anything like that going on. This is a perfectly healthy individual that caught this and was developing symptoms and an infection from it. There are no specific clinical features. We associate these night fevers, this cough, sputum production. We associate all of this with lung infections and tuberculosis and such, but none of this was there. None of this actually occurred. So we have nothing to go on. We had no clinical features. And other than that, I think we should talk about the travel history. He went to Djibouti and developed this. We are more apt to asking these types of questions when we see something like malaria or babesia or any along those parasitic infections. We want to know where you've been and where you've traveled. We don't usually think of this in a point of bacteriology, despite the fact that something like tuberculosis kinetii is more common in the Horn of Africa. So maybe we should start focusing in bacteriology more on what we can ask related to geographic terms and how that can help us aid in diagnosis. So just to go over some of the lecture notes that we've done in class that we've read, this is an important organism. This is one that causes a very clinical infection that has killed a lot of people, that is currently infecting people today, that is killing people today. It is one that we need to know and we need to be comfortable with. It's an obligate anaerobe. It does not form spores. It is non-motile. When you see it on the gram stain, it's going to be gram variable. This specific organism has a high lipid content in its membrane. It is acid-fast, so it is going to be an acid-fast bacilli. It is a slow grower, and it is non-pigmented. As far as media goes, we have our solid medias, our Lowenstein-Jensen, our Middlebrook 7H10 and 7H11, our Mitchinson 7H11. And for our liquid medias, we have our Middlebrook 7H9 and 7H12. So the types of tuberculosis. We have the Mycobacterium tuberculosis complex, and we have the non-tuberculous mycobacteria. I'm not going to talk about the non-tuberculosis mycobacteria, but it is leprae, we all know those stories. And as far as the complex transmission, it is a respiratory droplet, so it is spreading as these people are coughing and breathing and such. It is through the air. It's a slow grower. As you've seen for our negative result, it took about 14 days just for them to call that negative. So these things do grow out really slowly. We need to be aware of that. We need to be watching for that. If we suspect it, if these cultures are there, that is normally the policy. They're non-pigmented. Once again, they are the king of pathogens. That's why I said it's so important. This infection is still happening. It's still killing people. Pay attention to it. Be comfortable with it. And the ones that are part of this complex is obviously tuberculosis, bovis, africanum, kinetii, and microti. So definitely be comfortable with these and know what you're looking for. There are 3 types of infection: the primary, an extrapulmonary, and a miliary. Extrapulmonary, outside of the lungs. Our primaries are traditional, what we think of as tuberculosis, and our miliary is when it's disseminated and it is traveling throughout the body. It is an issue. They're all an issue, but that one is exceptionally an issue. And finally, these are your cited sources. Know where your information came from. I did source the initial article. It is the second article on there. If you do want to go read it for yourself, I do recommend you go read it. It's pretty in detail. I've more or less just given a summary. It actually goes into much more detail about the DNA, how the DNA probe works, and it's good information. And finally, I did source our professor for his amazing PowerPoint. Thank you for that. And that's all I have for you guys. So I hope you have a great rest of your semester, and I hope you do great on your finals. See you later. Thank you.